education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. The Searfoss Consulting Group specializes in giving medical professionals peace of mind when it comes to the business of medicine. We opened our doors in 2011 and really focus on what client services and revenue cycle management with strategic planning will look like in this post-health reform world. This presentation will address what you need to know about ICD-10 and specifically is going to cover what you need to do for your July 1st, 2015 to-do list. Just briefly, there's a number of resources that you can find on the SCG Health website. I highly recommend that you check that out. We do have a program for those of you that live in the DC metropolitan area that will be happening in May. Please check back to our site so that you can see more about what's going on. We also have a number of resources that we are making available as part of our birthday, so please check that out. We are turning 4 years old this year. The last thing to know is that a number of resources will be talked about. They are available for purchase either on the store here for the SCG Health website. We also will be talking about our preferred ICD-10 tool, which is ICD Logic. The system is called Cypher. So with that, let's go ahead and get started about what you need to know to be ready for ICD-10. So we're going to start backwards. We're going to look at the Go-Live date, which is October 1st, 2015. Many of you are aware that, guess what? Congress did pass the Doc Fix bill, a permanent Doc Fix bill. That bill went out and was signed by the President. That means that any legislative vehicle that would delay ICD-10 is already left the station. So if you have physicians who really believe that somehow there's going to be an apocalypse and this will be delayed further, the apocalypse actually is more about the implementation. We'll talk a little bit about that, because if people don't prepare for this, especially physicians and other clinicians, you're not going to be able to get paid. And sometime in October, late October, November, you'll have to figure out how are we going to pay our AR. So if we begin looking at October as our go live date, you begin to figure out that both September and August are going to be your timeframes to get things done. And I will point out July and August, with the number of folks going out on vacation, it's going to be a little hard for you. So the tentative calendar I've put out here for you just to think about is that you need to start planning immediately. We're looking at May right now, so that needs to happen immediately. In September and August, you're going to be looking at continuous coding and testing with partners. So let's build this plan. The plan that you'll lay out starting today is going to start with assessing your workflow, and I'll talk about why that is so important. It's not just about getting claims out the door, but also better documentation and how your clinicians and coders will find the appropriate code. Training needs to begin immediately if you haven't already started. And it's not just getting familiar with ICD-10 like participating in this webinar, it's actually getting familiar with the codes for your specialty. Training is going to need to be intensive, and it's an ongoing process. So if you notice throughout this timeline, I actually have continuous coding in there. I code once a week, and the reason for that is it's like a language. Just like I don't remember really much Spanish other than some rudimentary getting me through, where's the bathroom. It's because I don't use the language. And because of that, just that fundamental way that our brains work, coding has to be a continuous process. So if training begins in May, what you'll be able to do is continue that on throughout the time period once you have that established. But a big thing that needs to happen in May is talking to your partners, and we'll talk a little bit about that a little bit more. But that's going to include your practice management system, your EMR system, but more importantly, your health plans. And then the last thing that I want to spike out here is because ICD-10 falls under HIPAA as a standardized data code set, workers' compensation and all of their employers are completely left out of implementation. That means that you have to have a plan for dual coding if you have any portion of workers' compensation claims, because more than likely they will still be in ICD-9. Again, we'll talk a little bit more about dual coding. It's really important. Now in June, July, and August, again, understanding that you're going to have vacations coming up, some things to think about. One is setting an idealistic budget, and really that's about productivity loss. And again, we're going to talk about that, and also the fact that you're probably going to need to talk to your bank. Your training for staff really has to begin May, June so that you can begin this process in language learning for folks. And then also understanding what changes have to happen in your workflow, getting prepared for that, and training on the workflow changes. Now, by July, it's really helpful if you can go live with whatever systems you're using. And the reason, again, that that's important is because you're going to need to have the time to actually use the system and have the clinicians, coders, and billers understand where the information is. And that also allows you to test your workflow, because don't think that you can just all of a sudden go live October 1 and this is going to be fine. You need to test out the workflow. How are you capturing the codes? How is the information going to be there? Does the tool work? Does it not? Really important information. Around August and September, begin to look at doing audits of the charts. Does it actually work? Are your partners ready? But the last thing is, again, find those gaps and really begin to backfill it, because September is not the time to be doing that. As we all know, everything gets dumped back on your desk in September. So September needs to be really a quieter month where you can just glide right into October 1. So again, remember, your heavy lift needs to be starting today, and really look for a glide path through September into what it's going to look like in October. And down here I just have an awesome claim example for you using ICD-10. This is where we're going. That's what your claim is going to look like. So let's first start with a really interesting observation about the effective date. And this is becoming more and more of an interesting problem. Medicare has said no matter what, they are implementing on date of service. So don't worry about Medicare. Their implementation is on the date of medical service. We have a very consistent guideline out there, and we know about it. Now, for example, the way that that works is, let's say a claim happens for a date of service September 30th, and you submit it 2 days later on October 2nd, it's okay. Don't worry. It's on the date of service. That's an ICD-9. For dates of service on or after October 1, that's when ICD-10 will apply to claims, appeals, whatever it is. So remember, this is broader. So if you've got a resubmission, reconsideration, appeal, it's all on your dates of service. A very straightforward thing for you to think about, but needs to be a part of your training. Now, the problem we have with this, of course, is that not all health plans are following that rule. Talk to your business partners about that date, because is it on date of service or is it on date of submission? Really important. Now, two quick observations. For inpatient or home health or other things that have a discharge date, it's going to be dates of discharge that occur on or after October 1. So if you have a patient that comes in and you're billing for a service where the initial time frame they come in is on September 30th, but they're not discharged until, let's say, October 4th, guess what? That's going to be an ICD-10. So it's all about the date of discharge. Now, again, on a split claim bill, guess what? This one's a little harder. You're going to need to split your claims, and basically the services that were date of service on or before October 1, those will be on a claim with only I-9. For anything with the dates of service on or after October 1, that is going to be on a new claim that has ICD-10. So your split claims may also need to be further split. So what is the reality? Dual coding. This is going to be your reality for the first several months, because as you're doing appeals, as you're doing resubmissions, reconsiderations, remember you're going to be dual coding for a portion of that time frame. Now, the real great benefit is if you code in ICD-10, it's a heck of a lot easier to find your I-9 codes. If, however, your doctors and other clinicians are still billing in or documenting in ICD-9, it may be more difficult without additional information to code for I-10. So something for you to think about as you look at your workflow, because the effective date is a really important part of all of this. So let's talk about the reality. What we know right now from initial testing, again, done mostly on the hospital side, is that for a clinician, it's taking 5 additional minutes on documentation. And these are groups that are doing, again, large system groups that are doing actual coding in an EMR. They have to put in more information, and because of that, it's taking the clinicians a longer amount of time to get that all in. This is something that you can plan for and schedule for. Your schedule starting October 1 is going to need to allot for more time when they're coding in I-10. And again, if you implement early and have folks coding in ICD-10 before October 1, which is highly desirable, remember that you're going to need to schedule more buffer time in there for either dictation or other documentation requirements. Now for coders, while the system is very intuitive, and I actually really like it because I can find the codes a heck of a lot easier, it's going to be 20 additional minutes on average for a complex case because, again, you're learning a new system. So just remember that, again, this is on both sides. So clinical documentation and coding are going to have to take more time, which means that more than likely you're going to have some backlog that's happening. How do you want to address this? It's just like when physicians move to a new EMR system, it's going to look a lot like that. So how do you begin to plan for that? Schedule fewer patients, schedule longer periods of time. Your coders, maybe you're having not necessarily a one-day turnaround time on a complex case. Maybe it's only the easier cases that are going to be just one day. So again, think about from this standpoint how your workflow will need to change. So as we've talked about, there's some major changes that we need to think about for your workflow. And I'm going to come back to the super bill because this is going to be a really interesting problem. You are not going to be able just to capture information as you have in the past on a super bill. The biggest issue is figuring out how are you going to identify the right code, which more than likely means that you're going to have some lookup aspect. As I mentioned earlier, the SCG Health endorsed product is called Cipher. It is by ICD Logic, and this one we really like for a bunch of reasons, and I'll go through why. But again, there's a number of different systems out there for you to check out. Definitely look at it, because here's your issue: is that let's say you're using an EMR to do your coding. Is it truly a full code set? Is it easy to find? Is it able to have things like a quick list of categories? Is it completely integrated where in the EMR it's using the words that are in the dictation or in the actual note? And is it more than gems? So a bunch of things that we're finding with the EMR system that it actually doesn't work. So things to think about for that one, and I'm going to cover a little bit more with that. But your lookup, more than likely, is going to be that lookup system to find the right code is going to be the most amount of time that you're looking at. So a couple things to also think about. We mentioned on scheduling. For scheduling, just remember, again, that you're going to have to more than likely figure out either longer blocks or some other way to adjust for the fact it's taking longer time for documentation and also coding. Also remember, you need to work with your business partners for results. For your pathology, what does that look like? So your lab results, are they coming back with the appropriate codes? How are you getting the information? For your consults and referrals, how are they working on that? Is it going to actually be an ICD-10? When is there going to be change on that? Are you going to test beforehand? Really big things to think about from your workflow. So let's turn back to the lookup. The reason that this is such a big deal is that finding that right code so that the claim is processed the first time is going to be your biggest thing. Because again, if the claim doesn't have the appropriate code, it's not going to go through the coverage policies and be paid. So some things to think about when you're looking for different apps or other solutions, and again, the reason that we went with the Cipher product is that, one, it needs to be more than gems. And I'll talk a little bit more about gems, what is gems, and why things need to be a little more than that. So that's your first question when you're looking at any of the apps that are out there. The second thing is it should not just be a search by code or a crosswalk. Instead, you need to be able to search by terms, because some of the terms in I-9 they are not in I-10. Appendectomy is an example. So wouldn't it be lovely if you had a tool that can use I-9 terms that are familiar to a clinician and find the I-10 crosswalked different code sets? Fantastic if that system does have it, and by the way, Cipher does. It does need to have both I-9 and I-10 because remember you're doing dual coding. Very helpful, again, to think differently that crosswalk needs to be integrated, not just in the lookup tool. Also, it needs to have offline use. This is a big thing. What happens when your cell phone or tablet doesn't work, your Wi-Fi goes down? It needs to be a downloadable aspect that has offline use. I love it when you can tag favorites because that means I can go back and quickly see. It may be 50 different favorites, but it might be the thing that I'm using that day because I'm doing a series of different claims on a certain area. The last one, remember, is that ICD-10 is adopted by 136 different countries. Awesome, wonderful. But the U.S. version is different, and I had the misfortune of downloading a mobile app one that I wasn't paying attention, and it was in German because it was the German aspect. So make sure that you're looking for the U.S. codification of ICD-10. Now, one of the things, too, to think about is that again, from a workflow standpoint, how is this going to happen? What we're figuring out for many of the lookups is that it's either going to be on the clinician's phone. Since they're bringing their own device, why not let them use it? But the phones seem to be a little too small for most of the lookups. We are usually going to a tablet, so either a Microsoft Surface or an Apple iPad. Again, a little bit more space to see it. You can use either the smaller or larger ones. Some of the Samsung hardware items actually work better. But again, figure out what works for your office. Look at that. But the big thing is, can they actually use that tablet to type in information, easily get to it? Does it work well on that device? We are finding, again, that there's a number of products that are out there. Again, the one that we really like is the Cypher product, and I have to say they've been very responsive to some changes that we recommended. So why, again, is a lookup so important? It's important because you are not going to have enough space to put all of your super bill ICD-9 codes and transition it over to ICD-10. We tried to do that for a dermatology group. It was only a half page of the super bill. It ended up being 21 pages long. It is unrealistic for you to put your top codes there on your super bill. So more than likely what's going to happen, depending on how your office has it, if you do paper super bills, which again practices often do, what you're going to do is you're going to have some blank spots on the super bill where the clinician can write it in. Hopefully they have good handwriting. Your alternative to that, if they're not writing it in, is that you have it electronic, that it's integrated into either a practice management system or an EMR, and they just click the appropriate buttons and do the coding at the time of service. Again, the reason that this is so important is because, again, searching through and sifting through all of these codes is not realistic. So look at different options. You may come out that there may be some quick ones that you could put on a list, but again, more than likely if you do that, it's still going to be front and back to one of your super bills. So look at other options, and again, from a workflow standpoint, that's why we've gone to the lookup solution that is done on a tablet. So one of the other issues we're running into is the level of specificity that needs to be in clinical documentation. The majority of our training time is actually spent on this aspect because if it's not in the record, you're going to lose on appeal for all of your claims. Normally, what does a record look like? Down here below, I have a 32-year-old male, fracture radius, all now presents for surgery. It's usually a cryptic note, even in an EMR that has no information. So the reason that this matters is just to get into the fracture codes, which, by the way, is one of the most difficult portions of the data set. The orthopedic codes, all I can tell you is probably invest in some very hard liquor. But not only do you need to have, again, some information about the fracture, you need to have the laterality. You're going to need to have which bones it was. You need to have the type of the fracture. And again, also for codes out there is that you're going to be able to do injury for different types of sports. So again, this information is incredibly important and needs to be in the record. One of the other things, and again, where this record actually is not helpful, is whether or not the fracture is displaced. In the code set that we've set up for this one, this is actually out of a test case, it says that in an emergency surgical service that happens following that, so it's in the procedure note. But again, having physicians understand what they need to do so they can find the right code is incredibly helpful. So different things that you can do. If you are on still paper-based charts, this is going to be more difficult, but you can have a checklist of reminding folks what they need. Again, one of the reasons that we really like the Cypher ICD-10 lookup is because it actually has a checklist of what needs to be in documentation. Really helpful to help the doctors. But things, if you have it in EHR, your electronic health record can help prompt the doctors for different things. Is it a new or established patient? The laterality, right or left? The severity of different, again, diagnoses or injury. You can also make sure, again, that in the HPI and the review of systems, that there's information that's helpful. Use the MA. That medical assistant should be capturing information to help. But, again, using different templates so that you can figure out how, again, that code is going to be identified. Structure it so that the habits of precise documentation is established in your workflow so that you don't have to go back on every claim and ask for additional information. So one of the points that I made earlier, one of the concerns that we've had about the EMR systems is that they're using GEMS, which is the General Equivalence Mappings. These were developed by the federal government. They were doing us all a favor to come up with the baseline maps for us to use as we were looking at ICD-10 implementation. Incredibly helpful. But as I have an example here, and I just had tobacco use disorder, I use this all the time because of meaningful use in PQRS, but in GEMS, it only has one. It has nicotine dependence unspecified and uncomplicated. Well, what if it's not that they are, again, it's not unspecified or uncomplicated. What if you know they're smoking cigarettes? What if you know they're chewing tobacco? What if it's in remission? So again, there's a whole bunch of more specific codes that are available that don't show up in GEMS, which means that you need to have a system that does more than GEMS. This is one of the top questions that I highly, highly recommend that you talk to your practice management system and EMR vendors about if you're looking at using the embedded coding systems in their software. Is it more than GEMS? That's your question. How did you build your crosswalk? Then the second part of it, of course, is when you're looking at lookup solutions or other things to help your practice on implementation, just make sure that the baseline is always more than GEMS, because if it's just GEMS, you're missing a ton of the code set. Again, the reason that this matters is, again, if you're just using GEMS, you're just using as a baseline information source, you're going to miss a ton of codes that are available and need to be there for coverage policy. I'm picking on my former employer because, why not? And this is a Rituxan policy. Policies from most of the health plans are out there already. They are coded in ICD-10, so you can get information for your top coverage policies. Definitely go and check your top coverage policies and see what the codes are that are there. They will need to be on the claim for coverage. But just to give you, again, an idea, not all of the codes are going to be one-to-one matches, and that's the biggest thing for you to remember. Going from I-9 to I-10, there's not a lot of one-to-one matches. The majority are going to go into a one-to-many, or one with a choice, or one to approximate. So again, an example here is going to be your 4460. There are 4 different codes that United Healthcare in this coverage policy would be appropriate on the claim. I want to note here that none of the items listed here are not otherwise specified. The only one that you have here is an unspecified code. And again, that means that you have to eliminate all these other codes for it actually to be unspecified. So what does this mean? It means, again, that your clinicians need to be way more precise in their documentation. They need to choose the appropriate codes so your claim will be processed on the first time. But also importantly, your billers and your coders need to be aware of this so that, again, your claims are done appropriately and that there's a safety net for claim coverage. Just a reminder why this is so much more granular and such a big code set is because we've moved from having just, again, previously we only had this available. We have 2 additional items available and 2 different numbers here. It is an alphanumeric system. You will always have an alpha in the first place. Other than the letter U, there is no U in ICD-10. Instead, it's all about the I, and that's meaning that I am going to be coding correctly. So here, this is open dislocation of a metacarpal, and when you go in, it is actually a nice 1 to 2 match, depending on how it's set up. But this is a nomenclature that I love. It is intuitive. It makes sense. It's a true dichotomy. You can figure out going through the list where things are. So coders find it very helpful. It's just getting familiar with it. The first 3 are going to be your category. The next 3 gets into etiology, atomic site, severity, and laterality. And then if there's an extension, it's going to be your last digit. If, however, you don't have any information that's available in the after the decimal point, these first 3, you will be using X placeholders to get out to your extension, and here A stands for initial encounter. So again, very clear on the dichotomy, having different tools available, those good old-fashioned books that probably are going to be used as doorstops at some point in the future. That's helpful. Again, what's your resource to find all of these different codes? But in training, again, the system is intuitive, which means that train-the-trainer models have been the most successful that we've worked with. Generally, we like the train-the-trainer model where somebody is going to become, for your office and your specialty, is going to understand your codes specific to your office, your patients. They understand it pretty darn well. So where can you go to? Work with your local vendors. Talk to them, hey, what are you doing? talk with other practices in your specialty, and think about, again, associations and hospitals in your area so that there's local in-person training. I highly recommend that. Again, you can do the online training, but I've just found that it's not the same until you have that claim in front of you. The other thing just to keep in mind is that your office needs to figure out, using some frequent flyer patients, your top patients that come in all the time, what are their episodes? What are those codes that go through that? And then I create what I call Frankenstein charts, which look similar to these frequent flyer patients. You have some episodes, and then those become your baseline training materials. But as I said before, repetition is key. It's like a language. If you don't use this, you will forget the information. So remember, train the trainer models are great. SCG Health is offering a number of free training in-person events between now and October 1st. So just check our website about more information and the availability of that. So what is your homework? I said that's what this would be about for July 1st. What do you need to get done by then? The first thing that you need to do is understand your workflow needs. How are you going to address your business partners? How are you going to get the codes? How are they going to be captured? How are you training folks? Your workflow is really important because the super bill isn't something that you're going to be able to rely on. The next thing that, again, make sure you're talking to is your business partners. What's going on with Medicaid? Do they have the money to implement this? We would hope after all the delays that they have, but what's going on with that? If you've got workers' compensation, it's going employer by employer. Make sure you talk to them so that you know what's going on. But notably, too, just on that date of service issue, is it date of service or is it date of submission? Talk to your health plans, find out what's going on. Make sure you've talked to your EMR vendor. Make sure you've talked to your practice management vendor. Can you go live today and code in ICD-10? Find out what's going on. Look to your community about training opportunities and then begin training. It needs to start way before July 1st. I highly recommend by June 1st. Do your training, do that ongoing use of the codes, really once a week minimum. And then figure out when you want to start auditing claims. Again, I highly recommend for that glide path that you look at auditing claims sometime in August. When everybody else is on vacation, you have some time to get things done before Labor Day. And the last thing that I just want to highlight is, again, remembering to budget for Armageddon. You are going to need to talk to your bank to have a line of credit for when the health plans don't get claims processed on time or even per the coverage policies that they said that they were going to do and publish. But go ahead and make sure that that line of credit is set up, because as we learned with the 837 implementation many years ago, that right now we're looking at more than likely on October 1st having issues on claims processing. They may go ahead and just release claims without having it fully scrubbed, but at some point in the future they are going to start scrubbing and you will have cash flow issues. So with that, again, if anyone's on live, feel free to go ahead and put in any questions. I don't see any out there, so if you have any questions, you can submit those live now. Alternatively, you can send your questions to info@scghealth.com. That's a great place for any inquiry to go into because we do work that inbox. I also want to point out again where you can find resources on our webpage. So if you haven't visited scghealth.com, highly recommend it. We do have under resources the SCG Health store. You can learn more about Cypher by ICD Logic. Please make sure if you are interested, we can do a demo for you. Alternatively, right now we were able to get a very good discount price. Right now, the regular price is $75 for a subscription per month. We were able to get 60% off. You can get $30 a month per subscription. Use discount code HEALTH to be able to get that. The other thing, too, that we wanted to highlight for you is that we are putting out crosswalks and training cases. The training cases are, again, some case information for you to check out, show what documentation should look like, but it also includes the training key of what codes should be there. So more of those will be posted as we flesh out this portion of our website. The last thing, again, has to do with the ICD-10 training programs. So if you haven't already signed up for any of those, please be sure to check out. We will have more of those posted on the site. And we also will post all of our support materials. If you are looking today for handouts, you will receive, for those of you who listened live, you'll receive an email with more information. Alternatively, it will be on our ICD-10 resource page where you'll be able to get the handouts for the ICD-10 webinar that we just listened to. So with that, receiving no questions at this time, I do want to thank you for joining this presentation. For those of you that are listening to a podcast or watching a video archive on YouTube, please remember to rate the recording. To receive notices about upcoming Gimme 15-minute programs and other information, please visit our website, and you can sign up for the latest news, offers, and e-alerts on scghealth.com. Thank you for joining me for this 15 minutes education program presented by SCG Health. This concludes the presentation.